this is Tori, and this will be my clinical education case study. So first I'm going to start out with my patient information. This patient was a full code. They were admitted on the 21st of September this year of 2020, the age of 72. This patient was 5 foot 1 inch tall. They weighed 58.5 kilograms, and they had no known allergies. So the chief complaint for this patient was extreme weakness, fatigue, and extreme dyspnea, especially with exertion. Any exertion just kind of exacerbated all of these symptoms. The admitting diagnosis for this patient was COVID-19 positive. The current patient conditions included acute hypoxemic respiratory failure. This patient had ARDS. They had the pneumonia, which they acquired due to the COVID. They were in a hypercoagulable state, so, having thicker blood. They were very weak. They had acute on chronic kidney injury. This patient was experiencing hypoxemia. They were positive for COVID-19. This patient had diabetes. They had sciatica, hypothyroidism. This patient had dysphagia. They weren't able to swallow normally. And this person also had an essential tremor, which is a disorder of the nervous system. It is not curable. It's not related to Parkinson's. It can be treated with an anticonvulsant or beta blockers, but it can be cured. It's just like a shaking of the hands or feet usually. And this patient had no prior pulmonary or surgical history. Looking at this patient's conditions, they have a lot of things going on with their health. This patient is also older, and these are comorbidities. This patient is more likely to develop ARDS and more likely to develop COVID-19 because of these things. Then we took a look at the family history, the home history. This patient was retired. I don't know what the occupation was before they retired. Around here, most people are farmers, and so that's what I would assume, but like I said, I don't know for sure what their occupation was. This patient was never a smoker. They were on no home oxygen, no home therapies. This patient was doing relatively well up until their time of admit. So here's kind of what happened. The patient comes into the ER. The spouse brings them. They just are feeling extremely short of breath. This was on the Saturday before the admit. The patients developed a strong, dry, kind of hacky cough. They told the ER staff that with just very little movement, very little exertion, they were feeling extremely fatigued, extremely dyspneic. They were then admitted to the acute care. Because of these respiratory symptoms, this patient was swabbed for COVID-19, and that swab did come back positive. And so this patient was placed in the negative pressure room. Now, at my clinical facility, there is only one negative pressure room. And so this patient was placed in that room. The problem with only having the one negative pressure room and being part of a small community hospital is that right now the cases of COVID are really rising in this area, and so it makes it more difficult to have very many COVID positive patients because we have one negative pressure room, and so each COVID positive patient has to have their own staff, and so it makes it a little bit more difficult to care for these type of patients in this facility when the numbers are rising. But anyways, this patient was having a fever. They were still having that cough. They became shaky. They were, a fall risk, although this patient wasn't really doing a lot of ambulation at that time. And then as the time progressed, while they were at this facility, they required significantly more oxygen over shorter periods of time. This patient was placed on a non-rebreather, 15 liters per minute. They were doing easy PAP at 10 centimeters of water pressure, but they were only able to do about 5 breaths at a time, and then this patient became extraordinarily fatigued, and they required a significant amount of coaching as well as just full supervision when doing the easy PAP. They just weren't quite understanding, but it was important that we kept those lungs inflated and kept that volume in there, because this patient was completely unable to perform incentive spirometry. It was just very taxing, and the patient didn't quite understand, and so we felt that easy PAP was the best option for this patient. So the primary physician, doing rounds, came in, ordered an ABG, which showed that this patient had respiratory alkalosis, and they discussed with the patient, and the patient's family, that this particular patient was really declining, and that the primary physician would like to call the infectious disease doctor at a different location and just kind of discuss the condition and see what that doctor thought maybe would be the best for that patient. And so the primary doctor called the infectious disease doctor, and they discussed the case. And due to the lack of the sophisticated equipment at this smaller hospital, the two doctors, along with the patient and the family, decided that it was in the patient's best interest to be transported to a larger facility with more specialized equipment. So that's what they did. The current medications that this patient is on, the only respiratory med they were on was the albuterol HFA, 90 micrograms per puff, 2 puffs every 4 hours. That was indicated for the shortness of breath. And then this patient was also on Tylenol for pain, for fever. They were on dexamethasone, that was for the inflammation, Levinox for the anticoagulant. This patient was on furosemide, which is a diuretic to keep that fluid out. And then because of the diabetes mellitus, this patient also was on the Levemir Flex Touch. That was their insulin therapy. Then we take a look at this patient's labs. So looking at the white blood cell count, 12.2, that's elevated. Not terribly elevated, but it is elevated, which tells us that there is an infection, and we know there is because of the pneumonia. The blood urea nitrogen creatinine was 33, elevated. Hemoglobin was 13.1, that's low. Platelet count was 276. The INR was 1. That really surprised me because they were saying, that this patient was hypercoagulable. But I think because of that anticoagulant, it was kind of keeping that the blood thickness at an appropriate level. The one lab value that just totally shocked me was the D-dimer. The D-dimer level on this patient was 2410. That is extraordinarily high. When I see a high D-dimer, I immediately think blood clot, pulmonary embolism. But because this patient had poor kidney function, they were unable to do the CT scan because of the contrast, because they decided that the contrast could be more detrimental than the benefit. So in this type of situation, they weighed the benefit and risk and decided that the risk wasn't worth the benefit, and so they did not do a CT. But they did put this patient on the anticoagulant to try to kind of keep that under control. Then they drew the ABGs. It was drawn from the right radial artery on an oxymask at 12. It showed the pH at 7.53, CO2 at 23, O2 at 58, and the bicarb at 19. This is respiratory oscillosis. The patient was hyperventilating, but they weren't taking deep breaths, and so they weren't raising that PO2 because those breaths weren't deep enough. So the respiratory therapist was responsible for teaching appropriate breathing techniques to this patient to help this patient take a deeper breath and a more full breath. So because of what I kind of discussed before, only having that one negative pressure room, the COVID positive patients have one staff person that is with them for each shift, and this is going to be a nurse. So this nurse is taking care of all modalities of care for this patient to the best of her or his ability. If at any time they question something, they would call other specialties, whether it be physical therapy, occupational therapy, respiratory therapy, and ask questions. They get a fuller understanding of what needs to be done. And so that made this kind of an interesting case. This patient was prone to try to help with the oxygenation. The thing that I have noticed while I've been in clinical and seen patients or, looked over, reviewed patient charts for patients that have COVID is that proning is difficult. Whether the patient is intubated or not intubated, it's difficult when they're intubated because you're watching for, the ET tube, you're watching to make sure you aren't tangling things. But even when a patient is not intubated, it's difficult because compliance is rarely there. People do not want to lay on their back or stomach for a significant period of time. And so that's something that I found to be very interesting. While it can be simple and sometimes very effective, people just aren't compliant with this. This patient did have the elevated head of bed when they weren't being proned, and the nurse that was in the room, or if any other care provider had to go into the room for any reason, a face shield, an N95 or a PAPR mask, which is a respirator, a gown, double gloves, hair cover, and shoe covers all had to be worn by anyone that was in the room. They didn't get a chest x-ray for this patient, which really did surprise me. But because we know that COVID-19, these patients develop ARDS, I would assume that this CXR would show us a ground glass appearance. Then, talking about who's involved in this patient's care, like I've said previously, only one staff is in the room at all times, which at this facility is a nurse. But there's also a physician. The physician does come and do rounds. Maybe it's in person, maybe they do it over an iPad. RT is also involved in the same aspect. Over the phone, they can discuss what needs to be done to improve patient condition. And if need be, they can come into the patient room and show the nurse how to use certain types of equipment or how to instruct the patients on use of equipment. For this patient, they also brought in the infection control specialist, and that was done over the phone to try to determine the best care for the patient, and a pulmonologist was also involved. Talking about the ventilatory support, this patient was placed on BiPAP only by the flight team just before they were transported. Otherwise, they were on the non-rebreather at 15, which was just trying to keep those stats above 77 to 85. This patient did need ventilatory support because they were having respiratory failure due to the ARDS. And I was surprised to see that the patient was not put on ventilatory support while they were at the facility. Some of my suggestions to improve this patient's condition include high flow oscillation, devices for ventilation if traditional ventilation isn't going to work. APRV is a good mode of ventilation to use on these type of patients, as well as long as they are sedated. This patient really just needed to have improved oxygenation, and because this facility was small and didn't have all the specialized equipment, the transport of the patient to a larger facility really was the best thing for them to do for this patient. What I expected to see on discharge from my clinical facility was that this patient be intubated. Their severity of symptoms was just getting worse and worse. The D-dimer was really high, and I had heard about some larger facilities having these patients that have kidney injury drinking Mucomist, mixing it with Coke or juice, and that kind of acted as a buffer against the contrast, so it didn't cause as much injury to the kidneys, kidneys. And so I would be curious to know if that was something that they maybe did to check for pulmonary embolism. In 2 months, I would assume that hopefully if this patient is still with us, that they have recovered from COVID, they're back home. I would hope that the damage that this had caused to them, was minimal, but I would assume that they will probably be on oxygen, or at least oxygen with ambulation. I would also expect that this patient's family members were given the proper information on how to disinfect their home and keep themselves safe. I found some really great information from the CDC and from DHHS of Nebraska on the proper care of the home and disinfection while you have a COVID positive case at home or while there's been someone home. So just using those disinfectants as necessary. And then looking into a year. I would hope that within that year, unless this patient did succumb to the disease, that they would be back to a mostly normal life. I sincerely hope by then that there's going to be a vaccine for COVID, and that this patient will vaccinate themselves against COVID and the flu and just try to keep themselves as healthy as possible. I would assume that they're probably going to have several follow-ups with their doctor and pulmonologist. And here are my references for this case study. I chose this patient because I feel like COVID is so prominent right now. It's affected all of our lives with school and the way that we've done things through our clinical experience. Because I was very, very, very pregnant at the time that this patient was in my facility, I personally was not able to actually go in and assess this patient as far as their breath sounds or anything of that nature, but I was able to get the information and really look over this patient's chart, and I chose this patient because I think we can all learn a lot from ARDS patients. I think we're really going to be entering the workforce when we have such a high level of the COVID-19, and so to me this case study was just really, it was really a good choice for me because of those things. Thanks for watching.